I'm Louisa. I am going to be discussing the workability and disadvantage arguments for the case of physician-assisted euthanasia. I would first like to say that currently Oregon and Washington only allow for physician-assisted suicide, not euthanasia. Only Belgium and Holland, as Ellie stated, allow for euthanasia, which is actually the doctor injecting you. Physician-assisted suicide is where the doctor prescribes drugs for you, and you take the drugs yourself. And Shusek Kevorkian went to jail. Yes, he did. He went to jail for euthanasia, not physician-assisted suicide. So it was him directly killing the people. One of the main problems that comes up with this case is that a lot of these people who are requesting physician-assisted suicide are depressed. And the Oregon Assisted Suicide Guidebook states that any mental health consultation should be an evaluation of if they're competent, focused on the patient's capacity to make a decision, emphasizing that the presence of depression does not necessarily mean that the patient is incompetent. So even if they're depressed and are suicidal because of this, they can still be allowed to get the drug. Only if the physician believes that a patient requesting assisted suicide is suffering from psychiatric or psychological disorder or from depression causing impaired judgment must they refer them to a licensed psychiatrist or psychologist. And in Oregon, the percentage of cases referred for psychiatric evaluation dropped from 13% in 8 years between 1998 and 2005 to 4% in 2006, and this is a statistic from Herbert Hendon and Kathleen Foley's Physician-Assisted Suicide in Oregon, a Medical Perspective, their article. Studies have shown that physicians aren't adequately prepared to diagnose depression, and since they're not able to address and be able to diagnose this, why should we be leaving that up to their hands? Yes, they state that they need consultations with another doctor and a specialist, but who's to say that those specialists are able to diagnose it as well? And another problem with this policy is alternative care, palliative care options. They did mention that they do need to be offered to the patient, but only when a terminally ill Oregon patient makes a request for assisted suicide, physicians are required to indicate palliative care and hospice care as options. They're not required to be knowledgeable on these options and about how to relieve physical or emotional suffering in these patients. And without this knowledge, how are they able to push this issue of staying alive and staying with your family and being comfortable when they don't know it? They're just going to be pushing for this suicide option. Another statistic from Hendon and Foley's article, physicians recommend palliative care consultation in only 13% of the first 142 assisted suicide cases after the Oregon law went into effect, and it's unknown how many of these were actually implemented. So without it being talked about and offered, these people are dying without knowing their true options knowledgeably. And excellent medical care, including such as palliative care and other options, can control most symptoms and augment psychological, spiritual, and pain issues that the patient may be having and suffering from. My third issue with this is advocate interference. When the law went into effect in Oregon, groups such as Compassion for Dying sprung up, and they are for patients being allowed to die. And the role of an advocacy group and lay advocate in facilitating assisted suicide with a patient is troublesome. They form a relationship with the patient and the patient's family and coach them in how to access the law and find loopholes in the law to reach their goal of dying. They don't, however, know the psychological problems and family dynamics that may be influencing the patient's request for assisted suicide. So they're not adequate in assessing the situation like a physician would, which is why they should not be involved in this. But when the laws are in effect, there's nothing stipulating that they can't be involved and help these people find doctors, doctor shop for doctors who will let them reach their deaths. As was already mentioned, the slippery slope effect, it did spread into other states, but another problem with this is that it may expand to other groups. So right now, while it may only apply to terminally ill patients who are competent, it may expand to maybe non-terminally ill patients or persons with physical disabilities whose life quality they say is diminished, or even people whose pain is emotional instead of physical. So, and this is proof by, in the Netherlands, where euthanasia was legal, 900 patients were deliberately killed without request in 1995, and that rose to 980 in 2001, and that doesn't include the over 1,500 cases where palliative drugs were given with explicit and requested aim at hastening death. So while we may be stating right now that this is voluntary euthanasia, it will become involuntary euthanasia because doctors will be going around the law thinking about what is best for the patients, which leads me to my final point, that these laws give physician protection. They don't hold the physician liable for end-of-life care. There's a liability shield, which along with the incomplete reporting system, allows physicians to not be held to the same standards as laws when physicians may be just withdrawing life support. Thank you.